If you live in the United States, then I likely don't have to tell you about the growing issue of opioid overdose. In fact, you may have lost someone. However, if you're unfamiliar, 136 Americans die every single day to opioid overdose. To put this into perspective, you could almost fill a jumbo jet with the amount of people that die every single day. What if I were to tell you that there is not one, but two medications that effectively treat opioid use disorder and prevent the rate of opioid overdose death by nearly half? What if I were to tell you that due to widespread medical negligence, that less than 20% of people who are at risk for overdose actually will receive these medications this year? Before I continue, let me tell you a little bit about myself. Using illicit drugs saved my life. I grew up living with unrecognized and untreated mental illness. Things like PTSD, severe anxiety, a severe mood disorder. Illicit drugs is what helped me cope until they almost killed me multiple times. The first time I remember overdosing, I was on my bedroom floor with my mom standing over me. I'll never forget the look of horror on her face or the subsequent shame that I felt. The next time I remember, I was underneath an apartment complex staircase, this time with EMS standing over me. I doubt they will ever forget the look of horror on my face. Naloxone is what saved my life. Naloxone is a drug that reverses an opioid overdose. You might have heard of naloxone, as in recent years it's become more widely available in communities because of laws that have been passed, making it easier for lay people to have and distribute naloxone. However, what made one of my overdoses so peculiar was that we didn't use naloxone. When I was using, naloxone wasn't yet widely available in my community. In fact, I'd never even heard of it. We used a different drug. It was a small orange film that we would keep inside of our wallets. It's a drug that's not even proven effective to reverse an overdose. It's called buprenorphine. Actually, buprenorphine is a drug that treats opioid use disorder. In fact, it's one of the most effective treatments we have for opioid use disorder, second only to methadone. What makes buprenorphine and methadone work so well is that they're agonists, meaning they activate the same receptors in the brain that illicit opioids like heroin and fentanyl do. There are people that have been critical of these medications because of that reason. However, what makes these drugs so special is that the way they work is that they're only just mimicking the natural opioids that are produced in all of our brains. They're also known as endorphins. What happens with people living with opioid use disorder is that they're no longer able to sufficiently produce enough opioids on their own naturally. So we supplement them with medications like methadone and buprenorphine. This is similar to how we treat someone with diabetes, whose pancreas can no longer sufficiently produce enough insulin, so we give them insulin to supplement. I was not fortunate enough to receive methadone during my experiences as an injection drug user. However, I did receive a prescription to buprenorphine, and I consider myself so fortunate to have received that because so few have access to health care. What I remember about the first time I took buprenorphine is not craving heroin, which was very unusual for me. The other thing I remember more overwhelming but harder to put into words was this sense of normalcy, one that had been foreign to me for a long time. I did good for a while until my provider found out about another prescription medication that I'd been taking, that had been prescribed to me. Instead of having a conversation with me about it, he just discontinued my prescription to buprenorphine. The next day, I injected heroin again. Things continued for me, somewhat worsening, until I was coerced into inpatient treatment for the first time. Not all treatment is created equal. The first thing I remember about treatment is someone very unkindly telling me that I would have to give up the very things that saved my life. And they told me that I couldn't use buprenorphine or methadone when buprenorphine was the only thing that had helped me before. For 14 days I was there, and while I was there I experienced harassment, even assault. And I told the staff about it. They didn't do anything. I wanted to leave, but the medical staff, they told me that my insurance would not cover my treatment if I were to leave against medical advice. I later found out that that was a lie. I'd been held hostage there. So after 14 days, I took matters into my own hands and retaliated. I was invited to leave. The very next day, I injected heroin. Like the majority of people that leave abstinence-based treatment. In fact, studies show that 90% of people with opioid use disorder that even complete detox and psychosocial treatment alone will return to use. They also didn't tell me that my risk for overdose would be heightened because I had a tolerance before I went. Tolerance is what happens when someone uses an opioid frequently. They need more and more of it to achieve the same response. However, when someone detoxes, they lose that tolerance, and it's much easier for them to overdose. So, a few overdoses and arrests later, I ended up in inpatient treatment again. This time, voluntarily. And this treatment was much different. The people were kind to me. Some of them had even experienced what I had experienced. However, they still wouldn't let me have buprenorphine or methadone, which I found curious. After that, with exception to one occurrence of use, I haven't injected drugs in over 7 years. So what made me different? What made me different when 90% of people that leave abstinence-based treatment will return to use? I think there's a number of things, the most important one being my melanin deficiency. I was able to avoid getting in trouble very well because of the way that I looked and where I lived. I was offered treatment instead of incarceration. However, our friends and neighbors who are black or brown have a much different experience. They're disproportionately targeted and incarcerated. The next thing I had was a number of resources. I had insurance. A lot of people don't have that privilege. Not only that, my parents had some money. They were able to pay a copay for me to go to a nice treatment center. When leaving treatment, I didn't have a record because they let me go to treatment instead of jail. So I had access to gainful employment. I had access to safe and affordable housing. I had access to resources, to a whole community of people in recovery willing to help me. And that community did help me. I learned tons of life-saving information and received tons of help over the years. However, along the way, these well-meaning folks also offered me some dangerous misinformation. They had told me that buprenorphine, the drug that had once helped me, is bad and it's cheating. Methadone as well. They said that they discouraged people from taking buprenorphine or methadone. And if they did, they said that they weren't clean, which I guess the implication is that they're dirty. Some groups wouldn't allow people using buprenorphine or methadone to participate or share. Part of my privilege allowed me the opportunity to go back to school and not only finish my bachelor's, but my master's in social work. After, they even let me become a licensed social worker. I learned a lot while I was there, but it challenged me. I internalized those biases that I learned in the recovery community. In fact, I remember in my first social work class, we had a guest speaker, and he worked at a clinic that provided buprenorphine to people with opioid use disorder. And based on what I had been told, at the end of the class, I scoffed and told him that he was killing people. I've come a long way since then, through formal education and more importantly, from people who are directly impacted. Some of the things I learned included reading this study that was published in the Journal of American Medicine, one of the world's leading medical publications. In this study, they followed 40,000 Americans with an opioid use disorder for 12 months. And what they found is that the only treatments associated with reducing opioid overdose were buprenorphine and methadone. That is staggering. That should quash any moral or philosophical arguments against the use of medicine to treat opioid use disorder alone. However, what's also staggering in the study is that out of the 40,000 adults followed, only 1 in 10 of them received methadone, and less than 1 in 5 of them received buprenorphine. The stigma against these medicines are so ingrained in our society that even the professionals we look to help our loved ones with opioid use disorder will not utilize them. Another study showed that out of all the treatment providers in the United States, only 36% of them are even offering just one of those medications to treat opioid use disorder. That is because of the stigma. Of the providers that do this, many of them are for profit. People will pay as much as $12 to $20 a day to receive their medicine every morning. In my community, there is a nonprofit that will provide medicine to people that are uninsured or without money to otherwise pay for it. This is a great thing. However, there's a number of barriers in the way. For one, for folks to be admitted into the program, they have to have failed an abstinence-based treatment before and document that. Once they're in, they have to show up every single morning to receive their medicine and wait in line behind others and have their medicine administered to them through a window. This is quite the barrier for people with no transportation. Also, if they get accepted into the program, they have to do an intensive outpatient treatment program. What this means is that 4 days a week for 3 hours a day, they go into a group with other patients and a licensed professional. This is a good thing, right? We want our folks to have their needs met with therapy as well. However, when it's required, it often serves as a barrier and prevents access to the medication. I mean, could you imagine having diabetes and going to see your provider and you're expecting the standard of care, insulin, and they tell you, well, you know, before I provide that, you're going to have to try and manage your nutrition. So you try that and it doesn't work, and you go back to the provider and they say, okay, well, now I can give you some insulin, but for me to give it to you, you have to go to these nutrition management classes. They're 4 days a week for 3 hours a day. And if you can't go or you stop going, I'm going to have to withhold your insulin. We would never allow that, right? That's because in the United States, when we withhold the standard of care for a medical condition that has a name, and that name is medical negligence. Yet this is common practice in opioid treatment across the country. I'm so fortunate because for the past few years, I've had the opportunity to provide harm reduction services to people in the community. What this means is I distribute things like syringes and naloxone, the drug that reverses an opioid overdose. Even more, I've had the privilege of meeting more than 1,000 amazing people in our community, all of them at risk for opioid overdose. And I can say confidently that if tomorrow morning we had a provider open up that had accessible buprenorphine and methadone, we would have hundreds of people show up the very next day. They wouldn't end up like my friend Josh. My friend Josh lived in this community, and he was a special person. He saved countless lives with naloxone. So one day he got sick, and he was admitted to the hospital with an infection related to his injection drug use. He would have to be there for 6 weeks getting treated. Soon after getting there, he went into withdrawal. Withdrawal is what happens to someone who is dependent on opioids that is no longer taking them. It's like having the worst flu imaginable. In the hospital, because of his injection drug use history, wouldn't give him medicine to treat it. They wouldn't even give him buprenorphine or methadone, the standard of care. In fact, the hospital didn't even have an order set to give him that if they wanted to. Well, Josh was resourceful, so He decided if they weren't going to manage his symptoms, then he would. So he had a friend come in and bring him some illicit opioids. When the hospital caught wind of this, they banned Josh from having any visitors. So now, once again sick and in the hospital, and now alone without any friends or family, he left. And who could blame him? Over time, Josh's condition worsened, and he was readmitted to the hospital, only this time he'd be leaving in a body bag. He died there, sick, without his symptoms managed, alone, not allowed to have friends or family visit him, and likely very afraid. It is because of people like my friend Josh and the many others that are denied basic health care that we have to have reform in our policies with addiction treatment. We have to do what we know works. I personally am sick and tired of burying people that I love, knowing that we have the means to prevent this, but simply being unwilling to do it. There should be no one listening that's left wondering why it is that we have a jumbo jet full of people die every single day to opioid overdose. Thank you.